about facial neurologists and a typical facial pain. We previously talked about headaches and trigeminal autonomic encephalitis are included in this slide because it's included in differential diagnosis. So when we have a patient with a facial pain, we have to basically get a good history and get the flavor of what's going on. And it's actually pretty much the same evaluation for other pain conditions. You're interested in localization, right? You want to see where it is, if this pain is radiating, or where does it start. You're interested in the quality because I can tell you about also about the pathophysiology of the pain. Intensity is very important. This is important for the patients. Duration, because you can differentiate the pains according to the duration. And of course, any aggravating factors, like activities or any other factors. I would just probably remove activity from that slide, just say aggravating factors. Now, associated symptoms are also important: nausea, photophobia, phonophobia, any autonomic symptoms, any trigger points or other points that are in the history can give you a clue about the etiology and make it easier for you to diagnose it. Okay, so let's talk about trigeminal neuralgia because this is a very important facial pain diagnosis and very debilitating and required treatment. Now we defined, International Headache Society came up with the criteria in International Headache Classification for trigeminal neuralgia, and we have been using it since the late 80s. It has been slightly revised in 2004. And trigeminal neuralgia is basically defined as paroxysmal attacks of facial frontal pain that can last seconds to less than 2 minutes, usually a few seconds. And patients can have several episodes per day. You need to have at least 4 of the following criteria. One is it has to be distributed along the trigeminal nerve, and it's usually unilateral. This is a classic. It's usually sudden shooting, like electric shock-like pain. And it's severe pain in intensity. And it's a very common feature for this patient is that this pain can be triggered. And there are some certain triggered areas in patients. They can be from brushing teeth or eating or talking can come up. And usually the patients are asymptomatic in between the attacks, the pain attacks. Although we see sometimes they can have baseline pain, kind of dull pain in between attacks because of sensitization of the pain pathways. And there is a term called trigeminal neuropathy for that, but there's a huge debate about whether you can call that. But that's what, in a minority of patients, can happen. Now, a little bit on epidemiology and of localization. So first of all, the right to left ratio is 3 to 2. That's according to the studies. And it's very rarely bilateral. Most of the time it's unilateral and usually involves V2 and V3 distribution. And you can see here it's in 35% in V2 and 29% in V3. It can be combined in 19%. And only 4% it involves in so it's a very rare presentation if you have patients in this route. This is trigeminal nerve, this is ganglion, and it can be also in all 3 divisions in 15%. Usually we see patients in this distribution or this distribution, the pain. Now, another clinical features, basically repetition, duration less than 30 seconds, recurring repeated paroxysms. Right? Trigger factors like touching, cold, brushing teeth, talking. Now this is very important. That's the patients will ask you, what's going to happen, doctor, to me, right? I mean, am I going to get better? It's not good to have a trigeminal neurologist. You see here, the entirely asymptomatic, the patients who are entirely asymptomatic for years are only 6%, for months 36 and weeks 16 and days 16. Some patients have diurnal constant pain, like for example during night, for example, and 23% can have no recordable pain-free intervals, which is unfortunate, but it's pretty high. Now, if you look at the prevalence, it's not that prevalent, right? Compared to migraines and tension headaches, it's only affect around 200 people in 1 million. So, an annual incidence is around 3 to 5, or 3 to 6, I would say. And it occurs usually in the elderly population. So if you have a young patient with trigeminal neuralgia, always thinks of secondary etiologies, something. You need to be aggressive in evaluation of the young patient. Now, what is etiology? It's really hard to find a real etiology sometimes, and that's why you'll just call it idiopathic. But there is usually some sort of trigger, because we know that the pain is neuropathic, that there should be some sort of nerve injury, right? Most of the time, there is an artery which is kind of pushing on the trigeminal nerve around the ganglion here, and it's called arterial loop, and it's the area which, it's potentially surgical area, if the patient has not responded to medications. Now, if the patient has a chronic oral diseases, they can trigger, just like, the back pain, the neuropathic back pain is triggered by, for example, from radiculopathies and all those things. It can be triggered from that. Acoustic neuroma is another, consideration. MS plaques, now young patients, right, coming with the trigeminal neuralgia symptoms, you will always have to rule out MS because this is very unusual to have trigeminal neuralgia in a younger age. Arteriovenous malformations are also important in differential diagnosis because they're also operable, and that can be done something about it. Epidermolysis has been reported to be a cause. This is a more like neoplastic or changes also. Or tumors, any other tumors pressing on a nerve can also be a consideration. So always think of secondary etiologies. You see a patient for the first time, I think most patients get an MRI with a new onset of trigeminal neuralgia. Now, the pathophysiology, yes, there should be some local irritation of the nerve, right, which creates the spontaneous ectopic discharges, impulses. These are conveyed to trigeminal nucleus, and from trigeminal nucleus to the thalamus, the short, higher frequency impulses go to the thalamus, and then the pain is perceived in cortex. This is basically the distribution of, this is the anatomy of trigeminal nerve. You see here trigeminal ganglion, and goes to the trigeminal spinal nucleus, and from there up to thalamus. Now, this is borrowed from a European speaker, so where they practice evidence-based medicine, and they're not being sued as the doctors are as here. Then you can consider MRIs, because a lot of times when you have MRIs here, they just don't go, they're normal, and sometimes you just order them because you're afraid of secondary causes. But majority of cases are actually idiopathic, and you don't find any tumors, and then you can go after this criteria. So if the pain is rapidly progressing, it's the severe, you can consider MRI. If there is a sensory loss, that makes sense. If there is a sensory loss, you'll think of a mass, you'll order it here as well. And of course, younger patients, But we know that older patients also get MRIs these days. So. Now, the guidelines for management. So you get a detailed history and examination. Okay, you need to get a characterization of the pain. Then MRI if necessary. Then medical management. Now, we know the carbamazepine is a drug of choice in the treatment of trigeminal neuralgia. You can also use a trileptal, which is oxcarbamazepine, and lamotrigine has been used, baclofen, gabapentin, valproate. Lyrica sometimes can be used off-label, you try to use anything that helps, because if some of the drugs are contraindicated or cause side effects or are not effective, you try another. You can do sometimes. You can add another therapy to the carbamazepine, and sometimes lithium is used also for the patients for refractory pain. Unfortunately, associated with a lot of side effects. Then, if the patient cannot be managed medically, you tried everything, you should consider surgical management. Okay. Now, the surgical management. There are several options. There is a surgery at the level of Gasserian ganglion, radiofrequency thermal calculations. Have you guys seen any thermal calculations here? Dr. G did not do any?
I've done with her some blocks.
Blocks, yeah, Gasserian blocks, yeah. Right. Did she do any glycerol injections, or?
I haven't done any.
Right. It's becoming a little bit more kind of complicated and kind of more invasive if you use those procedures, because I will see they're associated with some side effects, and that's why a lot of times doctors are not willing to do them as the first choice. And then there is this posterior fossa surgery with microvascular decompression. It became very popular now. A lot of neurosurgeons do that. So now let's look at criteria for radiofrequency thermal calculation and glycerol injections. Age of the patients, you can use it at any age, and the type of anesthesia, you get generally short-acting anesthesia for radiofrequency ablation, light for glycerol injections. Some preoperative complications could be hemorrhage for radiofrequency and bradycardia hypertension for glycerol. They're both easy procedures. They're not as difficult to do, and it's usually day procedures, and you can get immediate pain relief with radiofrequency, and it can take some days for glycerol. Unfortunately, there is possibility for recurrence rate, and it's for almost 3 to 5 years for radiofrequency, and for glycerol is minutes anywhere from 2 to 3. So there is always recurrence rate, so it's not 100% a treatment. Then, of course, the complications. Anesthesia dolorosa is the most feared complication. Does anyone know what does it mean, anesthesia dolorosa? It's basically a pain. It's a nuanced de novo pain in the area where the surgery was performed, and unfortunately, it's a very refractory. It's a very hard to treat, and can be much more debilitating than the actual problem. So the patient would need to be warned about this possibility. I mean, you always have to weigh the benefits of the procedure against its risks, And you can get eye complications with radiofrequency. It's interesting, with radiofrequency, you can get keratitis because of the denervation of the cornea. And the muscle problems in the jaw muscles because of they're supplied by trigeminal nerve can also be affected. Interestingly, hearing complications have been also reported in radiofrequency and thermal calculations. Now, surgical management, microvascular decompression. Usually you want to have a younger patient for this procedure, and you need to give full anesthesia. It's basically a neurosurgical procedure. And they're rarely repeated, so sometimes you repeat the thermal calculation radiofrequency, you rarely repeat this one. And recurrence rate is at 2 years, 72% are pain-free, and there's a 2% of incidence of recurrence per year. It's pretty good results actually, and that's why we send the patients now for this surgeries. Did anyone assist or did you guys are from anesthesia? You got from anesthesia, right? Did you see any of those procedures? Yeah. Okay, so in terms of the side effects, anesthesia dolorosa has not been reported, which is very good, right? Rarely they can get diplopia. 23% can get hearing loss. This is a problem. I mean, but living with the pain, severe pain, and having a little bit of hearing loss, I don't know. It has to be you communicate with the patient. Now this is a diagram to show that another way of choosing the right patient for the procedure. Now the elderly patients are medically unfit. Of course, they're not surgical candidates. They go into the category of peripheral surgery and surgery at the level of Gasserian ganglion. And the posterior fossa surgeries are considered in younger patients, younger than 65. You guys in the practice, have you sent any patient to a surgery or to neurology? No? Okay, so you guys are good in treating the patients. Okay. It's also infrequent. I mean, how many you see, right? 1 or 2 months maybe, or something like that.
Dr. G is a couple that go for
yeah.
periodic blocks.
Right, Gasserian ganglion blocks. Now, glossopharyngeal neuralgia. This is very, very interesting, but also a rare condition. It involves the glossopharyngeal nerve, as its name implies, and defined as paroxysmal attacks of pain lasting a few seconds to 2 minutes. It's usually unilateral, and its posterior part of the tonsillar fossa, pharynx, and angle of the lower jaw and ear. Basically, the area of distribution, sensory distribution of glossopharyngeal nerve. The pain has a neuropathic pain quality, stabbing, burning, sharp, and it's very intense, severe. It can be triggered just like a trigeminal neuralgia. And I have seen a video of a patient from Holland. It's very rare, so it's very dramatic. I mean, the patient is in severe pain, like, you can see his face, how he suffers, and he has also this kind of reflectory like cough during that. And the guy was treated, and I'll tell you how, and he was completely pain-free afterwards. And of course, neurosurgeon got the credit, and not neurologist or a pain specialist. You will see the, so this is the anatomy of glossopharyngeal nerve. It's a very complicated nerve. It has parasympathetic distribution, it has motor function, it has a sensory function. And the sensory function in a way that you see the blue is a sensory nerves, and all areas I presented in the previous slide are shown here, and the nerve goes to the trigeminal nucleus, which is here. You see, this is the nucleus of spinal nucleus of trigeminal nerve, and from there, the second order neuron goes to the thalamus. Now, when you get a pain from glossopharyngeal nerve, on neurology, you can sometimes see autonomic symptoms, which is not unusual, because if a nerve is irritated here, you will also have irritation of other nerve fibers. And this is just to show some other involvement of glossopharyngeal nerve in the baroreceptor reflex and all those things. Now, there's no data on prevalence of glossopharyngeal neuralgia, because it's very rare. It's 0.7 per 100,000 people. And the average age of onset is 50 years. Nobody knows why why the patients get this. It could be a mechanical problem or irritation of the nerve, or could be just spontaneous, a genetic predisposition to that. They don't have any usually neurological deficits, and MRI usually is not helpful unless there's a tumor, which explains that. Now, the treatment is basically the same as almost the same as for trigeminal neuralgia, which involves carbamazepine, baclofen, lamotrigine, phenytoin. Any channel modulators, any anticonvulsants can be helpful here. Surgical, you can do radiofrequency thermocoagulation, microvascular decompression if you get an MRI and have a neurosurgeon look at the images. And of course, the side effects are could be dysphagia, persistent coughing, inability to speak loudly, because of the nerves involved in dysfunctions are very close to glossopharyngeal. Guidelines for management: you start with anticonvulsants. If they cannot manage, if the patient cannot be managed medically, you go to the surgery. Okay, so enough of that. This is a very common condition compared to the previous ones, and we see it quite a lot in pain practice. And any of the pain fellows have seen these patients with the postherpetic neuralgia and trigeminal distribution? Yes. How are they? Are they responding to medications, or you try Cutenza patch on them?
Some yes, some no, and some respond. Some
All right.
I haven't.
All right. So the definition is basically the same as for postherpetic neuralgia in other areas, thoracic areas, for example. It's a pain which develops after the acute phase of herpes zoster infection and persists for more than 6 months or thereafter. Now, if you ask Dr. Portnoy about the definition of postherpetic neuralgia, and he will agree with me on that, there's no really a time for defining it. Any pain persisting longer than 1 month is per definition is. Some studies say 6 months, some studies say 3 months. There is no really consensus on that. So I put it anywhere. I put like anywhere from 1 to 6 months after the onset of the rash. But you can say pain persisting beyond 1 month period. And it's usually distributed in the cranial nerve in V1 and V2 distribution. It can be any others. And the majority of patients are 60 years of age, and they are also immunocompromised or can have a cancer or some other states predisposing them to this condition. Now, quality is the constant deep burning pain. It can have a paroxysms of the pain, so it can have baseline pain with a paroxysm of the or exacerbations of the pain, and it could be elicited by mechanical stimulation, basically indicating the hyperalgesia or allodynia. And it usually involves V1 distribution most of the time, and it's actually the third common area involving the herpes zoster infection after the cervical and thoracic. And you can have a sensory deficits, basically numbness in the areas the patient can complain of. They can have also sometimes itching in the area, some disturbances in the sensory function. Now, the follow-up study shows that there is actually not bad prognosis for these patients. 25 had good outcome without any therapy, and 22 will benefit from the therapy, and 53 will have a poor outcome despite therapy. Then you have to use some other alternative treatments. Now, this is based on evidence-based management of the postherpetic neuralgia. So all these drugs have been shown to be effective in randomized controlled studies, and one of them widely used is amitriptyline and carbamazepine. Gabapentin pregabalin has also been shown. Opioids are also effective in postherpetic neuralgia, and of course topical lidocaine has been used as well. Now, topical capsaicin have a weak evidence, and in the practice we've been using the Cutenza patch for these patients with some very good results actually on some of the patients. Now we're going to talk about atypical facial pain. This is a kind of a very difficult and a kind of annoying disease because it's very hard to define, and it's also very hard to treat. We define atypical facial pain as a persistent facial pain which does not have a characteristic of neuralgias and usually doesn't have any organic cause or physical signs. It can be daily, it can be in one side of the face, it can be bilateral, it can spread to the neck, and also can cause the headache sometimes. We see it sometimes as a consequence of the chronic headache also. And usually normal imaging studies, and if you have few patients, and I know Dr. G is actually treating some of the patients of my patients sent to her. So sorry, going to go back. Now, there is no etiology. We know that they can have depression, these patients. Sometimes we thought of phantom tooth pain, if they had a dental procedure, where they should.
We have somebody in the hospital right now.
Really? Yeah. Yeah. And differentiation due to peripheral injury. I included myofascial pain because fibromyalgia can sometimes be perceived as a facial pain also. Now, differential diagnoses include dental pain, temporomandibular disorder, sinusitis, problems with the glands, tumors, facial tumors, and of course trigeminal neuralgia. But that would be very atypical with the presentation for trigeminal neuralgia. This is actually the good picture. It shows the distribution of the pain. Jaw muscles here, right? A little bit higher, actually here. And so it can be mid-face, but also lower jaw, and it's dull, usually intermediate to severe episodes. And it's very important that to be aware of a lot of patients can have depression, and it could be consequence. It could be sometimes a reaction also, the pain in this. and they have 90% have other symptoms like backache, headache, and generalized body ache, dermatitis, IBS, and a lot of other issues. And so the guidelines, it's always good to call Dr. Schwartz and to see these patients, because multidisciplinary approach is very important. You need to have dentists see these patients. You need to have ear, nose, throat specialists to evaluate these patients. You also have to be a little bit on alert, because you can miss a lot of real diseases in these patients. That's why you need to have, because if you have a facial pain, it can come from anywhere, any anatomical structure in the head, right? It could be from ears, it could be from eyes, it could be from from teeth, and from the brain, right? That's why you need to have a psychologist, neurologist, pain specialist, otolaryngologist, dentist, and ophthalmologist to see these patients. They're it's very costly, but I know, but this is very important to do. And of course, you have to eliminate all organic disease. You have to do the psychological assessment, cognitive behavioral therapy. We know that antidepressants are usually good in these patients, so that would be like Cymbalta, amitriptyline, Effexor would be the drugs of choice in these patients. And remember, talking to the patient, effective communications may prevent the long-term outcomes, right? The bad outcomes. And of course, we don't have any evidence at all from randomized trials on the surgery or any treatments for these patients. And we know, interestingly, they can actually get worse after the surgery. And so it's very important to involve psychology and psychiatry early on in these patients.